It's important to understand the definitions around decontamination processes. Decontamination comprises the two-step process of initial cleaning followed by either disinfection or sterilisation. Cleaning is the vital first step in the decontamination process and relates to the removal of visible foreign material using water and detergent. Organic material should not be allowed to dry before cleaning takes place. Low-level disinfection utilises disinfection to kill some but not all bacteria, viruses and fungi. High-level disinfection kills all bacteria, viruses and fungi but not spores. Sterilisation renders a piece of equipment microorganism free, including spores, and utilises the autoclaving process. Prions, however, are particularly resistant even to the sterilisation processes. It is important to recognise that some equipment is not designed to be reused, and attempts should not be made to disinfect or sterilise these items. Packaging will identify items which are either single-use or single-patient use, meaning that they may be reused on one particular patient. The Spalding classification, originally proposed in 1957, is a widely used system for matching the disinfection and sterilisation of surfaces, particularly those of reusable medical and surgical devices, with available processes. This is a three-stage classification: high risk, intermediate risk and low risk. Many items of anaesthetic equipment come into contact with mucous membranes and are deemed semi-critical or intermediate risk and require either high-level disinfection or sterilisation. Monitoring equipment and anaesthetic work surfaces fall into the non-critical or low-risk category and require low-level disinfection. Some items of anaesthetic equipment are recommended as single-use, for example endotracheal tubes, Guidel airways and suction catheters, as they become readily contaminated with blood and transmissible organisms. Please see the Resources tab for further information on this topic. High-level disinfection can be undertaken using readily available resources. As always, the first step in any decontamination process is cleaning. Items should be cleaned inside and out, removing all visible organic material. This could involve a bottle brush to clean inside a laryngeal mask airway, for example. High-level disinfection can be accomplished using 1,000 parts per million chlorine solution, which can be prepared as described here using household bleach. Another option is to use Precept tablets. Items should be removed after 20 minutes contact with 1,000 parts per million chlorine to reduce deterioration and ensure longevity. The final step in the process is to rinse the equipment in clean water, dry it, and store it in a clean sealed container. Some items of anaesthetic equipment are single-use and attempts should not be made to process them for reuse. Items that are frequently designated as single-use include oro and nasopharyngeal airways, tracheal tubes and suction equipment. Reusable items typically include laryngoscopes, face masks, laryngeal mask airways, bougies, stillets and McGill forceps. We can perform high-level disinfection using the processes described on the previous slide. It is important to remember that the first step in decontamination of any item is cleaning. With regard to laryngoscopes, the blade should undergo high-level disinfection and the handle a low-level disinfection. When we are using anaesthetic equipment, we should take care not to inadvertently contaminate our work surfaces. This is done by placing used equipment in a designated receptacle. Fibre optic bronchoscopes are also amenable to high-level disinfection, but this reprocessing is complex and best performed in the Sterile Services Department. You can read more about bronchoscope decontamination in the Resources section. Some anaesthetic breathing systems are made of silicone or black rubber and are designed to undergo sterilisation or high-level disinfection after each patient use. Perhaps more frequently encountered these days are single-use disposable circuits. These breathing systems have been validated for reuse over a 1-week period, assuming that a new patient breathing filter is placed between the patient and the circuit for each case. The circuits should be capped off when not in use. It's important to note that angle pieces and catheter mounts are, however, designed to be single use. Breathing filters are commonly combined with heat and moisture exchangers. They are of two different types, electrostatic and hydrophobic. Hydrophobic filters are of superior efficiency, achieving filtration of 99.999% efficiency. For non-critical anaesthesia items such as a blood pressure cuff, ECG leads and saturation probe, low-level disinfection is sufficient. In between cases, low-level disinfection should be undertaken including non-critical items, the anaesthetic machine and work surfaces and the wider theatre environment. This can be achieved using the same 1000 parts per million chlorine solution made up for high-level disinfection, but of course a shorter contact time is required. For many infected cases, or those patients that are carriers of bloodborne viruses such as hepatitis and HIV, there is little evidence to support placing these cases last on an operating list, provided a standard clean is performed between cases. However, there will always be exceptions, for example in the case of multi-drug resistant organisms. These cases should be placed last on an operating list and a deep clean conducted before the operating room is reused. Of course, these are only general recommendations and you should always follow your local infection control policy. In the video here you will see hand washing taking place. You will see use of a receptacle for soiled airway equipment, and also at the end of a case and between cases a low-level disinfection of the non-critical items. Prion diseases are a group of transmissible neurodegenerative diseases that can affect both animals and humans. They are caused by an abnormal form of the normal cellular prion protein found in neurons. These diseases can be sporadic, inherited, iatrogenic, or via dietary exposure, such as in the case of variant Creutzfeldt-Jakob disease, which arises from human consumption of meat